Hi, I'm Bryan Reisch, and I'm president of the Bryan Reisch Paralysis Foundation. I'm here with a couple of special guests, Samantha Troyer and Dr. Kurpad. Um, we're here to discuss some new and exciting things that are going on with research and where we've come and where we're going to go. And I'm excited to have Sam here because she's a recipient of a new epidural stimulator. And we have Dr. Kurpad here, who's expert on this type of topic. So, Sam, how are you doing today, and how did you get involved?
Well, I first learned about epidural stimulation over a year ago through working on research funding grant legislation for the state of Wisconsin, and discovered that in Minnesota in 2015, they passed similar legislation that was able to fund the eSTAN trial that further proved the viability of epidural stimulation with people who have paralysis and recovering function and reducing pain.
As a quadriplegic, what is your level? What do you have and what don't you have as far as movement goes?
Well, I have a C1 incomplete injury, the very highest vertebra in your neck, and I have more function to my right side, but my left side has been impaired for the past 16 years and been trying to recover more function there, as well as find a way to reduce the neuropathy that I deal with on a daily basis.
Pain's never fun, right?
It was the original development for the epidural stimulator was to minimize the pain signals the brain was receiving from the nervous system.
Sam, now dealing with all you're dealing with, we have an expert here, Dr. Shaker Kurpad, who is not only a neurosurgeon, but also a spinal cord injury researcher at Medical College of Wisconsin. It works out of Freighter Hospital. Shaker's been a longtime friend of the foundation and really knows his stuff.
Yeah, he even helped me on my path to getting the epidural stimulator in Minnesota. I had a referral with him here.
Shaker, how does this all work? Great to have you.
Thank you, Bryan. Thank you, Sam, for having me on this conversation. My name is Shaker Kurpad. I'm a neurosurgeon. I work at Freighter Medical College of Wisconsin. I'm mostly a spinal neurosurgeon, but have essentially spent my entire career, 20 plus years, on doing research and bringing new clinical trials to try and restore some function in patients who are paralyzed after spinal cord injury. So there are so many different areas of research that are being done actively around the world, including our own institution, to restore some function to patients who have suffered an accident or other injury, other mechanism where their spinal cord has been injured and has left them paralyzed with reduced function in their arms, legs, or both. Obviously, it's a very devastating condition. Most people are young. I mean, Sam's right here with us in our conversation. People at the that are at the most productive phase of their lives tend to get significant impairment in function, and as a result, there's a whole bunch of downstream effects that are negative, starting with the patient themselves. So, which is the psychological issues, not only the functional limitations and so forth. So a lot of work that's been done in historical context has to do with trying to see how quickly you can get to a patient with a new spinal cord injury resulting in paralysis, and what can you do that you can deliver in terms of treatment to try and restore some function or as much as possible function to those patients. That's where there's a difference between the strategy for epidural spinal cord stimulation versus all of the other research, which is also very important to try and restore function early on after spinal cord injury. So this is the only technology, the epidural spinal cord stimulation, that has been shown to have significant benefits in patients who have had spinal cord injury, have been paralyzed, and it's been a while since that happened, several years, months, years after the injury has happened. because a lot of these individuals, Sam is an example, will have some or all motor function, that is the ability to move one's hands and legs, taken away because of the injury. But then what most people don't realize, and is not well known, is that they also have a lot of sensory issues. So as opposed to losing sensory function, some of these unfortunate patients have significant super sensitivity, is one way to put it, to pain. So normally a touch to people who do not have an injury feels like a touch, but to a patient with a spinal cord injury, especially a partial injury where there's some function left, a touch can feel like a dagger is going into that part of the body. So that's called allodynia, or hyperalgesia is the technical term for it. So there's a heightened sensitivity to pain. So there's the motor function loss, there's the hypersensitivity to pain in a lot of ways, or the feeling that hot and cold exists when hot and cold doesn't really exist. So the spinal cord is sort of fooling the brain, so to speak. And then there's the loss of bowel and bladder function. So those are three big things that happen in a patient who loses or is deficited after a spinal cord injury. What spinal cord stimulation does is the history of it is developed for other reasons. So people who are not spinal cord injured but have chronic pain were the first individuals that were recognized as potentially benefiting from this treatment. This was 25 years ago. And the idea is, if you really distill it down, it's really a fairly simple idea. So what it is the spinal cord, you think of it as a fiber optic cable with nerves running in both directions. The ones that run from the brain downward work to make our muscles work. So those are motor nerves. And then there's similar nerves running in the opposite direction or functioning in the opposite direction that tell us information about our sensations: hot, cold, touch, pressure, vibration, other things like that. So essentially, if you think of the spinal cord, it's a fiber optic cable. The entire cable is tightly packed. It's about the size of a person's thumb. So it's really small, but there's a lot of concentrated function within that cable. So imagine when there's a injury to that cable, for that fiber optic cable, everything in that zone of injury where the blow has occurred to the spinal cord goes awry. So all of these, the mechanism by which the motor nerve fibers and the sensory nerve fibers work is simply by electrical conduction. So impulses are generated. So, a normal person without an injury touches something, that the touch, the contact with whatever you're touching gets converted to an electrical signal, and that goes up the nerve into the spinal cord and all the way to the brain, and it tells you you're touching something. So similarly, if you touch something hot, that's the same process where don't touch that stove, it's hot. And so on the flip side, for motor function, when you think of, oh, I've got to go take this coffee cup and take a sip of coffee, there's impulses that originate from that idea in the brain, converts to an electrical current, goes through the spinal cord, and then makes the muscles that you need to lift up your coffee cup and bring it to your mouth to take a sip. Superhighway going both directions. Motor downward, sensory upward is one easy way to understand it. And when you interrupt that circuit, then there's all these, there's a deficit of motor function, which we call paralysis, or there is a abnormal sensitivity to sensory function. So if you keep that in the back of your mind, now you introduce a spinal cord stimulator, you put that on the spinal cord around or above the region where the spinal cord is injured, then you can sort of like counteract, you can send a counter current to the sensory nerves in the spinal cord. So there's a current coming up that's an abnormal current in a patient with spinal cord injury, saying that there's pain when there's no pain. You turn on essentially a battery, and you turn on the stimulator, and you put in a counter current, and it sort of blunt out that abnormal sensation. So it's a neutralizing counter current.
It amplifies the signals not really getting through, or it's amplifying the signals, remaining signals that are in the spine.
So help me out here. Is this just a device that's implanted on Sam's back right above the injury, like a size of a...
It's implanted at T11 and T12. There's 28 electrodes that are connected to the dura layer of the spinal cord, the protective layer, so it's not in direct contact with the spinal cord itself. And the battery is then in the lower hip area, around L1 area. And then the epidural stimulator allows the lower spinal cord to communicate with the upper spinal cord, where the injury is blocking.
That's right. It helps to bypass the area of injury where the connections are not all intact. So on the sensation side, it serves to provide a current to neutralize these abnormal sensory signals that are trying to make their way into the brain. And on the motor side, it stimulates some dormant motor nerve cells that then are able to get these impulses across the zone of injury down from the brain because of the spinal cord stimulator and make some of the muscles work. Now, you would think that, if you and as Sam said, it's many points of contact in the electrode that are sitting not on top of the spinal cord directly, but on this membrane called the dura, which is outside the spinal cord. So think of the dura as a glove. So the spinal cord is your finger, the dura is a glove, and the stimulator lies on top of the glove. So that's sort of, where the spinal cord stimulator lies. And it looks like a paddle. It looks, if you look at it, before implantation or, just as a sample, it looks like a paddle with multiple points of contact. And the current is delivered through all of these points of contact. And you can all actually randomly choose which points of contact the current goes out through so that it can affect the spinal cord in a positive way. So that's the technology. So obviously you would hope that if you're able to modulate that current just so that you'd be able to restore all function. But obviously it's not so that you'd restore all these electrical impulses to where it used to be, which was normal. But the technology at this point isn't quite there, but it is at a point where you can restore some critical connections to remove the pain. Can you imagine just sitting, and knowing that one is paralyzed as a patient, and then, a breeze comes by your foot or your ankle, and this incredible sensation of pain is perceived when it's not anything that's a painful stimulus. So losing that abnormal sensation is a huge boon to a patient with a spinal cord injury. So this device is able to do some of what is logical. So remove some of the abnormal pain sensation, remove some of the abnormal temperature sensation, and restore some motor function, including bladder and bowel control, but it's not perfect yet. So the whole process needs to be fine-tuned as further research is done.
Does it vary on different people? Like, obviously, Sam, what have you all gotten back?
I've gotten some hand function and on my left side. Back, I've spent 16 years trying to get my hand to not always be in a fist all the time. Usually I'd be able to get like one good like finger movement out of my hand, and then it would just seize up and not want to work anymore. But since I've got the stimulator, I can open and close my hand repeatedly as I want. There's still a long ways to go because it's only been maybe 50 days since I received the stimulator, and I haven't even started therapy yet because they're quite booked up. But I'm, doing what I can on my own. And, the wrist hasn't come back yet, which if it did, I'd get way more fine motor movement back. But you can see I can repeatedly.
That's pretty incredible.
Yeah. And I've also got increased proprioception of my left leg and more stability when I'm like transferring. And I'm also able to sit up a lot easier when I'm in bed. I used to have to use my right arm to really force myself up in order to sit upright, but lately I've just like swung my legs over and I'm like, whoop, all right, I'm up, okay. Not really having to put a lot more effort with my right arm.
When you say proprioception, what is that?
Proprioception is the awareness of where your limbs are, like, what your limb is doing. Like normally I have to stare at my left foot to make sure that, it's going to stay where I want it. Like I have to stare at it while I'm pulling my pants up, because if I look away, it just kind of slips out from underneath me. And
you have no idea that's...
Yeah, so I normally just have to stare at it intensely when I'm getting ready and stuff, or when I'm trying to walk. And if I can get to a point where I don't have to stare at my feet when I'm doing things, it could really open up, being able to function better.
So where is this being done right now? It's being done in Minnesota. Where'd you go do it?
Yeah, I had to go to Minnesota because they were able to fund the proof of epidural stimulator working in people with paralysis, and Dr. Uzma Samadani branched off into her own clinic to implant patients outside of the research trials, because the research trials were mostly focusing on high level injuries where the people who were more incomplete weren't qualifying. So then I wanted to get it done there, and hopefully with more funding here in Wisconsin, we could bring it to this state.
Shaker, this really is an example to me of research that has been done over the years, something that's been about now, it's coming out to use, and it's being very practical. It's something that has come a long way in the use of technology to make our lives better. And it's awesome that it's being done in Minnesota. Is Wisconsin doing anything right now? Are you able to implant stimulators? Are there hurdles involved? Where do you see the future of this, and how's it going to go?
So, three great questions. I think the direct answer is absolutely it can be done in Wisconsin. Like I said earlier, placing spinal cord stimulators is standard of care for a variety of other problems. Implanting a spinal cord stimulation from a surgical perspective is quite common in a variety of places. So that could easily be done both at Fredericton Medical College as well as the University of Wisconsin-Madison. We're currently doing a lot of spinal cord stimulation procedures, not for injury, but for pain. People who have chronic low back pain or chronic leg pain or other conditions that result in intractable pain are getting those stimulators quite commonly. So the answer to that first question is yes. The answer to the second question is, I think, the application of a spinal cord stimulator to spinal cord injury patients for this particular purpose, which Sam has experienced such success with, that's not generally, considered standard of care yet. It's still experimental. But I'm also a spinal cord injury researcher, spent the last 20 years trying to figure out better treatments for spinal cord injury patients, especially the chronic, the people injured, more than 2 weeks ago. So a lot of the work has been done in restoring function to acute spinal cord injury patients. And every time I give a presentation or have a conversation with a patient with a spinal cord injury, I always get asked, what's going on for chronic spinal cord injuries? This is the first intervention that has proven to be effective. Obviously, you want to make sure that this approach works in more numbers of patients in a meaningful way. But the answer to your question about doing it in Wisconsin is yes, it's possible. It's being done for other reasons, other conditions. And second, we really need to mobilize our system in the state of Wisconsin to be able to do it, because doing the surgery will actually be the easy part. The approval is the harder part. So that's the funding for doing it is the harder part. And to your earlier question about why does it work? How do you know who it will work in and who it won't work in? That's the part that still needs to be understood about epidural stimulation, because spinal cord injury is a complex anatomical and physiological entity. So no two injuries are the same. So no two people, we say a person has a C5 or a C6, quadriparesis or quadriplegia, but if you took 10 unfortunate people who had that particular level of injury, the only thing that's common is the level. It's not the It's not about what's going on in the spinal cord. So every one of those people is going to respond differently to a spinal cord stimulator, just with some subtle variation. So that's the reason why it doesn't work the same way in every patient. It's a pleasure, always. Thank you.
Thank you.
I have to say, I've been injured for almost 20 years, and I've always said to myself, a lot of times I've always said, you have to have a dream, you have to have hope, and you have to live in reality. We've always had dreams. Sam always wanted to move again. I always wanted to move that hand again. I wanted to open that up hand, open her hand up and move those fingers. We've always been there. We've always hoped that would come true. But we have to live in reality. Well, it's exciting. It's really exciting that today, this is becoming reality. This is something that's happening today. This is something that's going to happen more in the future with combinations of new research, new ideas,
Better funding.
more hope. We can get there. And I believe with the help of individuals like yourself that are out there, I think with the continued progress that we're making, I think we can go a long way. We can continue to hope, we can continue to dream, and we can make reality that much better for people that are injured and for the people around us. We can make it happen. Sam, I have to say, I'm proud to call you a friend, just to say, to go forward with this technology and make it work.
Yeah.
You're kind of a pioneer. A pioneer.
Progress
So thank you.
doesn't happen unless you're part of the process.
You got to believe it.
Yeah.